This discussion is going to look at pain medications, specifically those that don't influence the inflammatory process. So we're going to be looking at how we kind of base our management of pain in looking at the analgesics that get utilized to decrease pain. The other thing we're going to be looking at are local anesthetics and their mechanism of action. So with pain management, we're going to be talking about different types of analgesics. We're going to be looking at over-the-counter and also looking at some of your prescription opioid-based analgesics. Basically, the way you're going to determine, or in the case of a prescribing physician, is going to be used based on the level of pain. So we have 3 different levels of pain. We have mild to moderate, moderate to severe, and severe. And we have general guidelines that we'll utilize that will dictate what type of medication that gets used. Now, in looking at these, certain ones, one in particular that we're going to be talking about, can be used to relieve both pain and fever. So one that we'll be talking about, acetaminophen, also known as by the brand name Tylenol, will be used to relieve both pain and fever. However, there's no effect on inflammation, so we'll be discussing how that medication works in relief of both pain and fever. As far as the onset of action, most of these pain management drugs will usually start to begin working within 30 to 60 minutes. However, if administered via an IV, they can start to work much faster. So the levels of pain that we're dealing with, again, mild to moderate, moderate to severe, you look to see the type of meds that basically are going to get prescribed. And the World Health Organization put together a management hierarchy, if you will, of kind of how to manage this. So typically for your more mild to moderate pain, you're looking at using just something like an acetaminophen or even an NSAID if applicable. Your moderate to severe, you start to look there. If a non-opiate is not relieving pain, you could look to prescribe an opioid-based drug and maybe even use a non-opioid drug as an adjunct to it. And then obviously at the severe end of things, you're looking at a higher dose of an opioid for severe pain and possibly using an adjunct non-opioid, again like an acetaminophen in that situation. So again, a lot of it will depend on the type of pain. Obviously, a lot of times post-surgically, it's not uncommon for individuals to be put on some type of opioid pain reliever based upon their level of pain. Obviously, if we could control pain with a non-opioid or a non-narcotic based drug. So for instance, when I'm saying opioid or narcotic based, I'm talking about things like morphine, and the such. You know, something that's not quite as strong like an acetaminophen, which would be, again, your brand name that would be Tylenol, would be more appropriate. Now, when we look at the opioid-based analgesics, where they're going to operate at is at pain receptors in the body. And there's 3 types of receptors that can possibly interact with opioid medications. Your mu, kappa, and delta receptors. And I have up there what the responsibilities are. Your mu receptors are responsible for analgesia, euphoria, respiratory depression. Kappa receivers are spinal analgesia, general sedation, and delta is euphoria and general sedation. So you can see an issue present here is that besides pain relief, these receptors do have other functions with the body. You know, for instance, the mu receptors also cause respiratory depression. So when we look at some of the adverse effects of your opioid-based pain medications, that's where those adverse effects can come in as well. So in addition to obviously being able to produce analgesia or pain reduction, these receptors have other responsibilities. looking at the relationship with the mu receptors, the most opioid analgesics are kind of match up with your mu receptors. That's the most common one from them to be. Their mu receptor agonist is usually what you look at when a physician prescribes an opioid-based drug. So if you look here on the picture, if you could remember that whole lock and key relationship that we talked about in the first chapter with how drugs, most drugs work with a receptor, you can see how the opioids work. Now if you look in the first one, you have the activity zone and the affinity zone. So when you look at a full agonist, okay, now in the picture they're referring to heroin. Obviously heroin's not going to be a prescribed drug, but you could replace that with any other prescription opioid that's going to be a full agonist. You can see the reason why, one, you get the decreased feeling of pain, but you also run the risk for greater side effects. So the greater that activity is, the more you also increase the risk for side effects versus, say, a partial antagonist where you can get the pain relief, but you're not going to get all the same side effects, okay, or you decrease your chances of getting them. So not all of your opioid-based drugs, they'll all have similar side effects. Some won't be as prone to causing them as others, and that's what this is trying to show. So again, your mu receptors, we went through the mu kappa and delta. When you're talking about prescription opioids, it's typically the mu receptors that they work with. So just general background on your opioid analgesics. They're all derived from opium poppy. They're considered narcotic based drugs. Morphine and codeine are probably some of the more common ones that you've seen. They are considered controlled substances, so they're only available by prescription, and physicians need to usually give some extra information in their prescriptions whenever they're prescribing a controlled substance. As far as uses, pain, they're obviously used in controlling pain. That's the most common thing, and that's what a lot of what we're focusing on now. Particularly pain that is going to keep somebody from sleeping. It's very important that, again, if pain is that bad, one, that other sources of pain get ruled out, but then that this type of medication be given. A lot of your antitussives will include some opioid analgesics. Codeine and cough syrup is a very common thing to see in cough medication. So if you're unaware of the fact an antitussive is considered a cough medicine, it's used in combination with non-opioid drugs. So sometimes they will combine an opioid with a non-opioid based pain reliever just to kind of add to the pain relief. And I have some common combinations here. One's with acetaminophen, one with aspirin. And in some anti-diarrheal medications, so they will actually use opioids, and that's because it helps. It slows down the transit time of the bowel, so it'll be used in anti-diarrheals as well. On page 137 in your textbook, it lists some of the more common opioid analgesics, along with their time to onset and their duration of action. So make sure that you note that in your textbook and take a look at that. So going over some of the adverse effects of opioid-based medication, one of the obvious ones is going to be your physical and psychological dependence. So a high possibility of abuse with these medications, and that's why they get listed as controlled substances, because of the potential for abuse. Withdrawal, respiratory depression, constriction of the pupils, urinary retention, nausea, vomiting, constipation. Constipation should make sense because it's going to slow down the bowel. And again, that's part of the reason why it gets included in diarrhea medication, because it assists with that, with limiting the diarrhea. And orthostatic hypotension, so that basically just looks at your blood pressure dropping based upon a standing position. Okay, continued adverse effects, tolerance. So if you've ever watched the television series House, if you recall, Dr. House was constantly taking Vicodin. I don't know of too many human beings that would be able to take Vicodin quite like he did. And not be tired and everything else, but his body basically likely developed tolerance for the Vicodin. Sedation and drowsiness, euphoria, skin rash, dry mouth, difficulty urinating. We talked about the urinary retention or the frequent urge. Now, just because you have the frequent urge doesn't mean that you're producing more urine. Part of the thing with a frequent urge is that your body might be building up urine, but you're not able to excrete it all. So you have problem urinating, your body's still going to produce the urine. So that's part of where the frequent urge. So don't necessarily get confused and thinking, well, you're saying difficulty urinating and urine retention, but then they're going to the bathroom a lot. The reason why they get that frequent urge is likely because their bladder's not emptying completely. And they should not be used prior to athletic activity. I mean, if somebody likely has to be on an opioid-based pain-relieving drug, chances are they probably shouldn't be participating in athletic activity either. So that's something to note as well. And the big thing is with your interactions is anything that could basically depress the central nervous system. So when you look at obviously, alcohol can depress the central nervous system. You probably shouldn't be consuming alcohol when you're taking an opioid-based pain-relieving drug. And other CNS depressants, so muscle relaxants, antihistamines, anything that has the potential to, when you look at things, basically think of things that could potentially make you drowsy. If you're taking another CNS depressant, if you're taking multiple CNS depressants, you run the risk for serious adverse effects if you were to do that. So if someone were to develop withdrawal, again, anytime you have a drug that could produce physical dependence, there's the potential for withdrawal symptoms. So we have listed here some of the different withdrawal symptoms that a person may have. So fever, runny nose, sneezing, diarrhea, goose flesh or goose pimples, dilated pupils, rapid heartbeat, irritability. So a lot of times when you look at withdrawal symptoms, you kind of look at, well, what's the opposite thing that would occur if someone were abusing something? And in a lot of instances that kind of makes sense when you're looking at what the withdrawal symptoms are. So if a person did develop a physical dependence to the drug and they had to come off of it, those are some of the different things that they would experience with that. So these are some of your more commonly used opioid-based drugs. So hydrocodone, oxycodone, codeine, myrpidine, which is also Demerol, and morphine. So Demerol and morphine are used in more severe pain indications. I mean, they're pretty much given to post-surgical patients who will be in a lot of pain and discomfort. Again, codeine is used a lot of times in antitussive medications. Again, you could see the time to onset and the duration of action of these in your book, so have a general idea as to how that works. And a question that I'm going to pose on the discussion board, why is tolerance typically less of a problem for most athletes? So that would be a question that you could answer if you kind of read in your textbook. There's a specific thing that they kind of point out why you typically don't see tolerance to opioid-based drugs in the athletic population, if you will. So when you look at, the typical, if you want to look at it as the typical population that we'll deal with in most job settings, why would tolerance not be an issue? Now, looking at non-opioid-based drugs in preparation. So we talked at length about nonsteroidal anti-inflammatories, which are also obviously pain-relieving drugs as well. There's a couple other ones out there. Propoxyphene. There's a very common brand name. A lot of people are familiar. A lot of people actually think that this medication is actually an opioid, and technically it's not an opioid because it's a synthetic drug. But you can see the brand name in your textbook. And it'll be one that'll probably ring a bell. It has a lot of the similar negative effects of your opioid-based, and most of them involve central nervous system depression. So a lot of the toxic effects of propoxyphene are CNS-based depressive effects from that drug. Again, look at the brand name. The brand name will probably definitely ring a bell with most people when you're reading about that. Capsaicin is a non-opioid based topical medication, and it's actually derived from hot chili peppers. So what they find is that it actually limits the activity of some of the chemical transmitting, or the chemical messengers in the nervous system that transmit the pain signal. So they do believe that, as a topical drug, capsaicin is something that can provide some pain relief by limiting some of the chemical events that go on during the pain process. A very common over-the-counter pain reliever is acetaminophen, which has the common brand name of Tylenol. It is both an analgesic and antipyretic, so it can help with reducing pain and reducing fever. All of its effects are in the CNS. It is not an anti-inflammatory. Now, it is believed that one of the potential mechanisms as to how it relieves pain is by inhibiting cyclooxygenase in the brain. Okay, so this is not the same effect that you have with taking ibuprofen or naproxen sodium. It's a different aspect of dealing with the cyclooxygenase enzyme. It deals with it strictly in the central nervous system. Some benefits to Tylenol. There's no gastric irritation. There's no effect on platelet aggregation, so it doesn't affect blood clotting. There are no kidney effects. And it's very safe to take before activity, so it is a safe, very safe over-the-counter medication if taken appropriately to help with pain and fever reduction. So it'll get absorbed in the gastrointestinal tract relatively quick. You're looking at about 325 to 1,000 milligrams every 4 to 6 hours. The maximum daily dose is 4,000 milligrams. And Tylenol or acetaminophen has a ceiling effect, meaning that giving more than that will not have a greater pain relieving effect. So going beyond that, you're not going to continually get greater pain relief. So, and to top it off, at that point, you're starting to get into some potentially dangerous side effects if taking more than that dosage. There's various forms of acetaminophen. In some instances, it is combined with other substances. There's no risk of rise with it, and again, another benefit is that there's little risk of bronchospasm. So if you have an aspirin-sensitive patient, particularly one obviously involved in sports and athletics, Tylenol could be a good alternative for pain relief just because you don't run that risk of having the bronchospasm. If you remember when we talked about the anti-inflammatories, some patients are a little sensitive to that because of the suppression of the other, the cyclooxygenase enzymes. The expression of the leukotrienes will cause them to possibly predispose them to bronchospasm. So some adverse effects and interactions. Most of your issues with acetaminophen, Tylenol are going to be because of overdoses. So 2 to 4 days of overuse. Again, 4,000 milligrams in adults is the peak amount they should be taking. And again, you don't want to be taking this for numerous days. And again, anytime you're having pain beyond a certain time frame, you should really be getting looked at. Make sure you're getting looked at by a doctor anywhere under a doctor's care. It is very toxic to the liver when taken in high dosages for a long period of time. Think about what would be signs of liver toxicity. So jaundice, yellowing of the skin and eyes is a very common one. Nausea, vomiting would be all things that would be associated with liver toxicity as well. You have to be aware of your consumption of alcohol with Tylenol. Again, Tylenol is going to be very stressful on the liver. So at the same time, consuming large amounts of alcohol could possibly cause issues as well. And then warfarin. Occasional use with warfarin is all right, but again, you want to make sure that you probably want to discuss that with a physician if a patient was on warfarin. So now looking at local anesthetics. So an anesthetic is any type of drug used to produce a complete or partial decrease in sensation. So if you've had a simple, even if all you've ever had done is a simple filling at the dentist, you know, what you get injected with first is an anesthetic to help reduce the pain from the procedure. They're all originally derived from cocaine, and they're administered via an injection typically. There are some local anesthetics that can be applied just topically, but in a lot of instances, especially for medical procedures, they're applied with an injection, so that's the parenteral route. Good thing about these is they have very few adverse effects, and the adverse effects that they have are usually associated with overdose. So within the right dosages, not a great chance of having any adverse effects from these. The adverse effects that you look at: CNS excitation or depression, cardiac arrest, or possibly allergic reactions. So again, as long as there's not an overdose of the anesthetic, you typically don't have a problem with them. So whether injected or just applied topically, they're administered in the periphery of the body. Many times epinephrine will be added to a local anesthetic, and what this does is the epinephrine allows for a longer duration of action of the anesthetic, and the reason why it does this is because it produces vasoconstriction. So the epinephrine produces a vasoconstriction of the blood vessels, which will prevent the anesthetic from being moved out of the area. So it'll kind of, I guess the simplest way to put it is that it keeps the anesthetic or the numbing agent just in the area for a longer period of time, because it'll diminish blood flow to the area slightly and allow for that activity to be prolonged with the anesthetic. As far as how they work, they both inhibit the ability to conduct action potentials and inhibit the number of nerves getting activated to the CNS. And the way that it basically affects the layers of the peripheral nerve, it simply basically looks to affect the outer fibers of the nerve first, and then as it gradually penetrates, it will go to the deeper part of the nerves. They're on figure 10.3 in your book. It kind of looks at absorption rates for local anesthetics, what types of tissues will produce a rapid uptake of the anesthetics and which have a little bit of a slower uptake. So if you remember, you probably discussed in therapeutic modalities class your A delta and C fibers, or both of your pain fibers that get activated due to injury. So your A delta fibers, if you remember, are the fast, sharp type pain producing, typically what you experience with acute injuries, whereas type C is your chronic, dull, aching type of pain sensation. Both of those pain fibers are very easily penetrated by an anesthetic, so it allows it to have that numbing effect on the tissue. So some of your common types, you have lidocaine, bupivacaine, and procaine. So again, they have that cane suffix, and again, that comes from cocaine. In other words, these were derived from the drug cocaine. Some can be in topical preparations. You may notice that when if you get a sunburn and you go out and buy some type of sunburn lotion to help with the discomfort from that, a lot of them have lidocaine in them. I think is typically the common one that they have in there. Some of them may have some others, but I'm pretty sure the lidocaine is what you usually see. They're classified based on their duration of action, and I have the durations of actions up here. The injectable are only available by prescription, so you can get topical forms over the counter. Anything injectable is going to have to come via prescription. So I'm going to talk about counterirritants a little bit. A counterirritant is not an anesthetic, but again, the counterirritants are things that are very commonly seen. Flexol, Icy Hot, Tiger Balm. Those are all examples of counterirritants. Now, the way counterirritants work is this. They do not actually heat up the muscle, okay? What they do is they actually produce a mild inflammation of the skin. So it's really the sensory stimulation. It basically functions If you go back to your pain relieving or your levels of pain control, this is classic level 1 pain control with the counter irritant. It produces a warming sensation or a cooling sensation if you're talking about something like a biofreeze that basically interferes with the sensation of pain. Okay, so they are effective at pain relief. It's just they're not effective for the reasons why most people think they're effective. You know, most people when they put Bengay on, they think that it's actually heating the muscle, and it's actually not heating the muscle. It's just basically producing a warming sensation on the skin, which helps to reduce pain. And again, when you do that, it can help with range of motion and things like that. So certainly there are benefits to that. I just give some examples here. We talked about capsaicin a little bit earlier. Again, the interesting thing about that counter irritant, it's actually derived from chili peppers. So that's kind of an interesting thing. Menthol, methyl salicylate, or just a couple others that you may see in a lot of your over-the-counter products that you'll buy in the stores. And a lot of times they can be used in combination as well, so not uncommon to see that. So if you're ever looking at your analgesic balms, again, your Tiger Balm, Bengay, Flexol, you name it, this is what we're talking about as far as how they relieve pain. So this is what I was talking about earlier. You can get these topically as well, and they'll contain the suffix caine or amine. Caine are usually stronger and can potentially be more toxic, so you have to watch how much you're using at one time, how long you're using it for. So even in the over-the-counter preparations, if used for if used too much or excessively, you can produce problems. They're not intended for long-term use. I gave the example how a lot of your sunburn lotions will have one of these types of anesthetics in them to help relieve pain and the discomfort from the sunburn. So for pain and itching relief, they can be used, but again, you need to watch the duration for how long you're using them for. Refer to the labels. Unless a physician tells you for a longer period of time, they shouldn't be applied any longer than that. So your different uses of these types of anesthetics, so I gave the example of the dental procedures, but even something like sutures. So if anyone has ever had stitches done, you likely had a local anesthetic applied as you were getting the suture done. So you could do both peripheral nerve and central nerve blocks with them. Your topical applications, we talked about with skin irritations, how a lot of, they particularly have a lot of over-the-counter options for skin irritations. Ethyl chloride spray or cold spray is also used as an anesthetic. A lot of physicians, when they're doing injections to for joints and other soft tissue issues, will use an ethyl chloride spray prior to the injection to kind of numb the area a little bit. There's a picture on the slide here of ethyl chloride spray actually being used in trigger point therapy. Some people will use what's called the spray and stretch technique, where they will spray the area of the trigger point and usually go along the lines of the trigger point pain referral. And there's people who will use this in combination with stretching, and it tends to work really. It tends to be a really effective thing. A lot of people are very big on using that, particular when there's any type of myofascial trigger points in the cervical region. They find that it can be beneficial, and people do it anywhere. I've seen even in one of the therapeutic exercise textbooks, they show a lot of even just ice and stretch, using an ice cup for that. So they can be combined with other drugs. We talked about the combination with epinephrine. And the injectable can be used for pain management with certain injuries. So sometimes they'll use injectables as long as it's in an area that you can't have any further damage to. So, you always hear of people getting injections and, well, is that going to cause, more potential issues? A good physician will only give an injection for pain management with these things if there's not the potential for further damage. A lot of times, for instance, they'll do injections for subacromial bursitis, very common, and they'll usually combine an injection in that instance with an anti-inflammatory in that situation. So they'll do like a a local anesthetic coupled with an anti-inflammatory. And actually what they'll do is they'll sometimes just use the anesthetic for diagnostic purposes. Some physicians will, if they're unsure if, like, say, go back to the subacromial bursa, if the subacromial bursa is irritated, and again, we know that just even through our own clinical evaluations, it could sometimes be difficult to differentiate what tissue, particularly in an area like that, is exactly causing the pain. What they'll do is a diagnostic injection where they will inject an area and see if the person's pain has actually gone away. If they inject the bursa and the pain goes away, then they know the pain is being caused by the bursa. So a lot of times they will do that diagnostically as well. So we talked about the mechanism. They all basically work via the same mechanism, whether they're injected or whether they're topical. The idea is they just block the conduction of the nerve impulses. Again, I would suggest you take a look at that figure in your textbook, page 141, figure 10.3. It talks about, you know, how some of the different areas will take up, how fast they'll take up the anesthetic, but it's essentially just blocking that nerve conduction via those mechanisms we described earlier. So some other considerations or things to look at when you're using either anesthetics or even the counterirritants that we talked about. Don't use counterirritants in combinations with heating pads and tight dressings. So, you know, particularly your methyl salicylate, a lot of times that the vasodilation that will occur in the skin with a heating pad will cause systemic absorption of that, so you need to be mindful of that. Beyond that, just the application of the counterirritant coupled with a hot pack or even a tight dressing for that matter will just cause it to become very uncomfortable for the individual using it. They do make special pads and dressings with the counterirritant on it. That's perfectly fine as long as you're not, you know, again, putting any extra tape or wrap on them to make them tighter, because it could just be more of a benign discomfort that the person gets, which you don't really want, but at the same time you do run that risk of also the systemic absorption as well. So just, you know, you wouldn't want to combine those two things. And as far as the NATA and the international doping associations, everything except IV injection of local anesthetics is legal. So, and the IV is banned only by the NCAA, so there shouldn't be any IV injections of local anesthetics. And these are your learning outcomes. So again, do your reading in your textbook. Make sure you pay particular attention to some of the things that I pointed out throughout this discussion.